So I do love teaching on contact dermatitis. It's something that I deal with every day, but so do you all who are seeing general derm and even subspecialized derm. The eczematous dermatitis permeates our schedules routinely, and it's really something that should just cross your mind when you see some stubborn eczema. These are my disclosures. I'm really not going to be talking about therapeutics. The main issue in this lecture to disclose is I'm going to talk about non-FDA approved allergens, which are above and beyond the true test patch test. So, just because I knew this was happening, I think this was Tuesday. So this was this Tuesday, and it was a patient with recalcitrant face dermatitis and neck dermatitis. And you can see it's pretty sharply cut off, right? So this is one of those quintessential clinical circumstances where you say, I think this is contact dermatitis because it's so sharply defined. Could be photo allergy, could be airborne allergy. And these are her patches. This is just this week. And you see in this 90 section, citral and geraniol, and these other patches are all fragrances with a nickel. And when you get deep into the story, you're finding that she uses frequent aromatherapy in her home. And more importantly, she uses natural bug repellents on a regular basis in her home and outside. And citral and geraniol are the major ingredients in these kind of naturally sourced bug repellents. So this one we just blew wide open today, but it's an example of when you see, you kind of know there might be something unusual going on here, and you patch test. So just to open up a little bit, these are the top allergens on the left and the bottom allergens on the right of the North American Contact Dermatitis Group Standard Allergen Series. And I think fundamentally, that's probably the best place to start. True test just on itself, you're going to capture a third of the people who you think have contact dermatitis, and the rest you're going to miss. And if you're an aficionado of the true test, when you look at this list and you look at the first two columns, you're going to immediately notice that so many allergens are missing, and they're top players now in contact dermatitis, so you're just not capturing them. So a couple of notable issues here. Nickel has been the #1 patch-tested allergen for many decades, and it's that way internationally. By far not the most common contact allergen in North America, which is urushiol, poison ivy, poison oak, poison sumac. That tends to cause dermatitis and contactants most of the time. But nickel #1 patch tested. In yellow, I've highlighted preservatives, and you notice we'll talk more about methyl isothiazolinone and then the Kathon one. And then in green, I have fragrances. And then you see some miscellaneous ones like paraphenylene diamine and the antibiotics bacitracin and neomycin. And then still in the top two columns are rubber allergens in pink, and then some other miscellaneous ones which come up a whole lot. And then if we look at the bottom allergens, there are things we used to think about a lot, like tosylamide formaldehyde resin. Everybody thought about that for eyelid dermatitis or face dermatitis and nail polish. Imidazole, lidinylurea, and parabens. I mean, that's always in the front of our mind as preservative allergens, and yet they're really at the bottom of the list. Now, every year, the American Contact Dermatitis Society issues an allergen of the year. Basically, it's a bit of a dubious distinction for people to just basically pay attention to some new emerging allergen that we wouldn't think of at all, or shifts in the exposure patterns or the epidemiology of that particular allergen. So you'll see on the left side some pretty classic ones like paraphenylene diamine and cocobetane and neomycin and bacitracin. And on the right side, there's some stranger ones like alkyl glucosides, isobornyl acrylate, acetophenone azine, and very rarely have you heard of those things. And it's just to raise some attention. So we'll touch on some of those. But I think if you are thinking about patch testing, one, it's just the right way to go if you want to thoroughly work up an eczematous dermatitis that is just escaping what you think is good treatment. And the North American Standard Series is a great place to start. So just to think about this in the context of eczematous dermatitis, and I use that term pretty broadly. So I use eczematous dermatitis often in my assessment. I keep it pretty broad. The biopsies tend to come back spongiotic dermatitis. And within that umbrella, we have atopic derm, irritant and allergic contact dermatitis, nummular derm, id reactions, and I can be so bold as to say perhaps spongiotic drug reactions. But they all kind of look the same. They all are erythematous, variably scaly and crusty, variably lichenified, and they're really hard to tell apart unless I show you the lady I saw on Tuesday with a sharply demarcated dermatitis on her neck and face. So when we think we have an atopic, when we think we have a classic eczema and it's not getting better, think about some of the data out there. So this 2018 study, difficult to treat AD, defined as failure of 2 or more topical therapies. When this group is gone ahead and patch tested, this was a whopper, right? 3/4 had concomitant allergic contact dermatitis. And in this study, almost 40% were sensitized to multiple allergens, lanolin, wool alcohols, cocoa betaine, the surfactant, and the contaminant in cocoa betaine is dimethylaminopropylamine. These are the allergens we look for, and fragrances. This second bullet is from a paper we wrote looking at all of the contact dermatitis data in atopics. And we really found that the evidence suggests that contact dermatitis really is nearly a comorbidity of atopic dermatitis. And the most frequent allergens we tend to see in atopics were lanolin, fragrances, preservatives, and corticosteroids. And if one just thinks for a second, all the stuff atopics are putting on, it's these very things. Right now, just a few weeks ago, the North American group looked back at their atopics, and 1/5 of them had positive reactions to 1 or more allergens over and above the North American series. So this is patch test allergen 71 to say 150, right? And the greatest at-risk group for positivity to supplemental allergens were the atopics, were the ones with the long-standing eczema. So our current NYU standard series has 135 allergens on it, and then we add supplementary allergens to that. But starting with the basic 70 or an ACDS, American Contact Dermatitis Society 80, will get you a good number. And then when you add supplemental allergens and you see them coming up positive in your population of patients, then you can start adding them to your standard series. But look at this classic patient, gets sent in for patch testing, got a long history of atopic dermatitis, little antecubital fossa, little bit on the neck, and there's always that one finger that doesn't get better, that's hard to treat. I would say sort of a mild atopic, and a very smart referring doctor. I'm like, okay, they think they have contact derm, let's check. And this is her back. And it was just stunning to me with methylchloroisothiazolinone, methylisothiazolinone, fragrances, cobalt, and nail polish in this case. And the removal of her allergens resulted in near total resolution of her dermatitis in classic atopic areas. So it's just numbing to see that, but it's motivating to consider patch testing your atopic patients that don't get better. So if we look at just generally vexing areas of dermatitis that always stymie us when we're trying to treat them, eyelids, right? So if we take 50,000 patch tested patients across North America, about 1 in 20 have just eyelid dermatitis when they present for patch testing. Now keep in mind, there's a little epiphenomena here, right? These are patients who the clinician referred in because of suspicion of allergic contact dermatitis. So the moment your head goes there, that's this group. And ultimately, over 40% of these eyelid dermatitis patients that got sent in for patch testing got a diagnosis of allergic contact dermatitis because of the patch testing. And the classic eyelid dermatitis patient in this study that was very large were Caucasian women over 40 with a history of atopy. And the common allergens were the top allergens to begin with: nickel, fragrances, MI, balsam of Perusa fragrance, and gold, which causes ectopic contact dermatitis. Interestingly, when both eyelids were involved, right? So you had two eyelids, not just an eyelid dermatitis. Things like carmine, which is red pigment in cosmetics, shellac in mascaras, dimethylaminopropylamine and olemetapropyl-dimethylamine. Those are surfactants. Those are soaps in facial cleansers, shampoos, and makeup removers. And then thimerosal, which I think is becoming less of an issue. The other one is hand eczema. So hand eczema is also very hard to treat just because of the location and the thickness of the skin and stratum corneum there. But when you have recalcitrant hand eczema, my gut is to go to patch testing. And the most common allergens for hand eczema are the most common allergens. And what I'm pointing out here is eyelids, hands. If you have a pretty decent sized patch test standard, you're going to find these patients without having to dig extremely deeply, right? So here's a guy with recalcitrant hand dermatitis. You could see, and he had dermatitis elsewhere on his body. And I threw the book at him. He had some on his axillae, on his thighs and groin. And he had a boatload of positive reactions on his final reading. And he's another case where you might not think just by looking at these hands, I better put the patch tests on. But, you know, they come in with Ziploc bags full of 8 different tubes of medicine that they've tried that don't work. Something must be creating a headwind to this getting better. And I'm going to pivot because of the hands and occupational relatedness and COVID, where people are getting a lot of rubber exposure. So this is a thoracic surgeon who every time was on call would self-medicate with prednisone because he would have to scrub in to do thoracotomies on call or, you know, put chest tubes in. And his hands were a mess and he was disabled by the thing. And this is his back, right? So he has a standard series coming up positive with rubber. And then on the right side, I have a rubber series. And, you know, believe it or not, we found appropriate gloves for him that he was not allergic to. And I could barely get the guy to do follow-up anymore because he's clear. Of course, I'm showing you the heroic and great cases. And not everyone has a positive patch test, but the patients are grateful for even trying. Right. So for gloves, which comes up a lot because during COVID, everyone was wearing gloves and there's still people who wear them very frequently, including everyone on this call. So recall the rubber accelerators. The accelerators are used to increase the speed of polymerization of natural latex rubber, but also synthetic rubbers. A major misunderstanding that the rubber accelerators are just for natural latex gloves. In fact, they are used routinely in nitrile gloves. So you have the Thiorams, the Carbamates, the benzothiazoles, the guanidines, and the thiourea. And the Carbamate and Thiorams, when they're positive, and they are often positive, they are generally relevant. The hard part's finding out where, because it may be an eyelid dermatitis or face dermatitis, and the patient's using a rubber wedge to put the makeup on, or the eyeshadow has a little rubberized tip on there, and that doesn't immediately come to mind. We used to think, for some of you who are practicing maybe 10 to 30 years, that Thiorams were the most common cause of hand dermatitis from rubber, and it turns out more recent studies would suggest carbamates are by far the most important. So I think for general exam gloves, when people are doing housework, I like these Nighthawk gloves. I have no conflicts with any of these things. Nighthawk gloves are not accelerated and don't have antioxidants. And I've just listed a couple of surgical gloves that are sterile. These Gamex ones and these Dermashores are great for people who have accelerator allergy. And sometimes the rubber exposure is just not obvious. This patient came in, I thought all the world had psoriasiform dermatitis, and I could see stigmata of psoriasis on her, but this was so stubborn, it was so isolated, and the patient was sent in for patch testing, and I was going to dutifully do this, right? And as I'm leaving with the hand on the door, she starts donning these finger cots. I was like, wait, what are you doing? And she goes, it's the only way for my fingers to not feel like they're ready to crack, right? So already I got a rubber exposure that's following the psoriasiform dermatitis. Here's her patch test. There's her feet with the rubber insoles. And this is her after just getting rid of the rubber. I still have a bit of psoriasiform dermatitis there, but I don't have the degree of rage that that dermatitis had. And just one other food for thought, and just to provoke you a little bit, this is the prevalence of reactivity of rubber allergens over several decades. And I will tell you, the red line, the Thiorams and the Carbamates, we had on the NYU Standard Series in 1930s. In 1938, we published our Epidemiology, and those allergens were on there. And it has been relatively flat. And then I'm a medical student around this time here, around 1987, and there's a glove shortage. And we see at the same time, there's a record spike, a doubling of the epidemiology of Carbamate and Thioram allergy. And this completely coincides with CDC issuing universal precautions because of HIV. And for those, again, practicing in the 70s, maybe in the 60s, even in the early 80s, most were doing shave biopsies and injections barehanded. When I went to the dentist in the 1970s, my dentist did not wear gloves. I was just happy if he was wiping his hands on his shirt to clean the saliva off the last patient. I was grateful for that. Then everybody overnight started wearing gloves. We had glove shortages, and I had to put IVs in barehanded. And we were starting to get gloves that were poorly manufactured, that had poor quality control, and we saw a spike in this. Also saw a concomitant spike in immediate type hypersensitivity to latex that was causing anaphylaxis. So to consider the COVID pandemic, we wrote an article that we published in Dermatitis about 1.5 years ago, saying, are we going to see a spike in rubber reactivity 2 and 3 years from now from all the rampant use of personal care personal hygiene protection, gloves across the world? It wasn't just in healthcare workers, it's been everybody. So we'll see. You heard it here if it happens, and if it didn't happen, I'll remove the slide from the next talk. Metal allergy, as you saw, nickel was the most common patch test allergen. And in fact, for nickel, piercing is probably the likely source for many nickel allergic patients. So you take 9,000 patients and you look at them before testing. And 42% of the people who come in for patch testing are not pierced. And less than one in 20 have 5 or more piercings. So let's say, you have a pair of earrings, a couple of temporal horns. And I think on the lower left, a sensible thing, epaulets for your steak knives. I can never remember, bread on one side, drink on the other. I never can remember what nostril to put your steak knife in. So this guy put 2 in, solved the problem. Now, when you look at those reacting to nickel, it flips. So those who were not pierced, who were 42% of the patch tested individuals, represent 9% of the nickel allergic people, and the 5% that had more than 5 piercings represents a third of the reactors. And if you look, it just goes in this linear fashion. The more piercings you've had, the more likely you'll be allergic to nickel. That does not hold up for cobalt, and for some reason is inversely related for chromium. So one thing that I might add, if you pick up a nickel or cobalt allergic patient, it is useful to tell patients in generalities where these metals might be found: belt buckles, zippers, coins, that kind of thing. But having them get nickel and cobalt spot tests is invaluable, right? The dimethylglyoxine test for nickel turns pink when the applicator is put up against the metal and it doesn't ruin anything. And the naphthol disulfonic acid test for cobalt turns orange in the presence of it. So you send patients home and say, go get these tests. They sell them on Amazon, and test where you think you may be getting exposure, because you're never going to be able to do that in a reading. Like, you need hours and it wouldn't even work. They have to go home because you're not living with them. And here's an example of a lady who came to see me, was going to get dental work, had terrible hand dermatitis, and a pretty bad eczematous dermatitis. She wanted to know before they implanted metal what she was allergic to. And indeed, she was allergic to nickel and cobalt. Here's cobalt over here and nickel here. And there's some other metals like palladium down below, which were relevant. And she avoids these metals, and we treat her, and she does great, but she has this persistent little plaque under her arm, and we cannot get it better. Like, she's using clobetasol, it works for a while, then it comes back. Another hand on the door, aha moment, just an epiphany. She's walking out and she's got her bag on, and sure enough, this metal ring is dimethylglyoxine positive. How would I ever have predicted that if I hadn't seen it? So it's just good. It saves us time, saves us a lot of explanation, and you put the patient to work for 2 months testing all the metals in their activities of routine daily living. Another thing that I come across is patients just love natural products. They just can't get enough of natural products. I was giving grand rounds in the Pacific Northwest and went into the shower and saw this, and it just made me crazy, right? Like, Sprout Out conditioner, just like Mother Earth used to make. I'm sorry, I must have missed some kind of catastrophic Earth event where all of the conditioner plants were wiped out by a meteor. It didn't happen. This shower gel is so green, you'll grow leaves. Why do I want to do that? I don't want to grow leaves. I don't believe Mother Earth ever made conditioner, but people are just sold on that. And one of the quintessential ones in the top 20 is lanolin. Another is, you saw shellac and you saw propolis and balsam of Peru. These are as natural as the driven snow. Lanolin escapes our consciousness sometimes. So lanolin is derived from the sebum of sheep. So I don't know, some thousands of years ago, someone got the idea that this ghastly creature, its sebum, its oil, held the secret of human health and beauty. To me, it's like going to the person next to you, rubbing the oil off their nose, and then you putting that on your lips, because that's what this is. And we know lanolin is associated with higher rates of contact dermatitis in atopic children. They're constantly using lanolinated products like Aquaphor and the old Eucerins and many other lanolin products. And in stasis dermatitis in older patients, that group is also at risk for a lanolin exposure and higher rates of contact dermatitis. And it winds up in the strangest places, right? Like in eye pencils, right? Or in often many lip balms have it. And of course, what happens? The more chapped your lips feel, the more often you put this on. The more often you apply it, the more you need it. And you see the blurred vermilion border. This is all from lanolin. All these cases are from lanolin, and all result in complete resolution upon removal of lanolin. So always stick with your petrolatum when you're not sure. Preservatives, as you saw a little earlier, they're one of the main families of allergens. causing allergic contact dermatitis. And over the years, over 5 to 10 years, we're seeing a precipitous reduction in the rates of allergy to the formaldehyde releasers. You know, when I was training, and for the 15 years after that, Quaternium 15 was the #1 preservative allergen across the continent. And in a couple of years, it went down by a third. It's not even close. And remember the other formaldehyde releasers, bromonitropropane, imidazolidinylurea, DMDM-hydantoin, and diazolidinylurea, they're all on the downtrend. They're still important. When those things are positive on patch testing, they are almost always relevant. Like, you have to find where it is. You have to have the patients dig up where it is and then start using products that don't have it. Parabens, we spend a lot of time thinking about, and I'll mention it a little bit later. And preservatives are still a very important cause of contact dermatitis in children and infants. And you'll never be able to tell that apart from their classic endogenous eczema, because it's all just red, itchy, lichenified skin. And where are you putting the topicals? On the itchy, red, lichenified skin. So that's the quandary. And I just wanted to show you the high rates of probable relevance of these allergens. And you see things like iodopropanol butyl carbamate popping up as top allergens, and they're things we don't even think about. That's a non-formaldehyde releaser. I'll mention Cathon and some others that the only way you're going to detect them is not by guessing. It's going to be by patch testing them. So here's a guy with axillary dermatitis, a blistering reaction to Quaternium 15 present in his underarm deodorant. And you see mixes of formaldehyde releasers and non-formaldehyde releasers. We have bromonitropropane with MI, or for this styling gel, DMDM-hydantoin with iodopropanol butyl carbamate. And perhaps the reason we're seeing lower rates of formaldehyde allergy is because the concentrations of them are coming down in products as they blend preservatives together, which has been very helpful. MI, the allergen of the year in 2013, a very brilliant allergen of the year. As you could see, if we track about 12 years, we're going from about 2.5% to 5% to 11% to 13% to 15%. That's the most recent data. Now, hopefully we'll start seeing reductions in contact allergy as manufacturers are taking note to it. But one thing, TrueTest has the Cathon patch test, which is MCI-MI at 200 parts per million. But if you don't test to 0.2% or 2,000 parts per million, you're going to miss 2/3 of the people who have MI allergy. Now, it's been banned in leave-on products in Europe, and in fact, you're seeing reductions in reactivity. We're seeing new isothiazolinones like benzoisothiazolinone appearing in cosmetic products, and I've recently added it to my standard series. And for some reference, nearly every water-based house paint contains MI or an isothiazolinone. Now, I mentioned in my conflicts on the list there, I'm on the cosmetic ingredient review, and we review the safety of products in cosmetics in the country. And we came out that MI was safe for rinse-off products at low concentrations, and in leave-on products, the concentration needs to be reduced to be non-sensitizing. So, you know, one take is to get rid of it, and it will be replaced by another new chemical that might take us years to figure out. This is sort of the one we know, and the one we can test for, and the one we can avoid, and the one we can make some adjustments on.
May I ask a question? May I interrupt?
Sure.
Sorry, you were having such a good flow. But we just got a question from Dr. Jenkins, who asks, just going back to your petrolatum comment, is an allergy to petrolatum a valid entity?
Oh boy, okay, that's a tough one. And if you scour the literature, you will come up with an article here and there about petrolatum allergy. I have a hard time sort of verifying that. I think the last one that I saw an article was from Brazil 10 or 15 years ago. I don't think petrolatum is a real allergen, especially refined white petrolatum that has had some of the heavy hydrocarbons distilled out. I don't think it's an allergen. Nonetheless, patients who are atopic or patients with some cheilitis or eyelid dermatitis might report burning and stinging from the application of petrolatum. And I think it's an occlusion effect, and it may be a solvent effect, because petrolatum is a heavyweight hydrophilic solvent. So I don't think it causes frank delay type hypersensitivity. I think it causes some sensory issues. I don't think it's an allergen. And look, there are some people who you've patch tested that are not allergic to lanolin. They love lanolin-related products, and that's okay. But in the absence of knowing, I think it's an easy one. When someone comes in with cheilitis or eyelid dermatitis, just get rid of it. You don't have to go to patch testing. Just try that first. Are there a question? You know, I'll finish MI here and I'll pause. But you see this hand dermatitis patient, and I have a yellow arrow. That's the Cathon patch test. That's the same concentration on true test, completely negative. But at 2,000 parts per million, it's positive and was the result of the recalcitrance of the hand dermatitis. In contrast, here's a lady using wash-on, wash-off products, and she has terrible face dermatitis. The low concentration and the high concentration are both positive. She has a very low threshold for reacting to MI, and avoidance was pretty helpful. So I can pause before I go to parabens if anyone has a question or comment. Let me look in the chat.
There are no current questions in the Q&A and chat, but we do want to encourage folks. You know, one of the things that we are trying to do is really build a patch testing program here. Many of you are getting the training, but it's just really the standard training for how to apply it and how to store it. But there are so many questions, as you can see, that come up about relevance of patches, that I think it's useful to kind of sort out these things that we're seeing in clinics. So definitely, if you have questions, you can put it in the chat or the Q&A. I believe, Mark or Jamie, there's also another way to raise the hand so that people can also speak. I think it's on the bottom right corner.
And Toby, if you see one pop up that I might not be able to see because my screen is largely the slides, just pop in.
Absolutely, thank you.
And so the last preservative are parabens, and everyone's worried about parabens, and yet they're really not major contact allergens. And you could see the positivity rate is about 0.5%, and it's not for lack of being in products. It's because it's not a very strong sensitizer, particularly as the concentrations have gone down. In fact, it's used far more than methyl isothiazolinone, and yet has these really low rates of reactivity. So we tend to call that parabenoia. There's some suggestion about endocrine disruption, but parabens are in products for 100 years. And I don't think there's any good data to suggest that the way parabens are being used in cosmetic products poses a problem for patients. So I want to highlight an important one. And, you know, as Toby's mentioning, I'm sort of rallying the use of the patch test to diagnose patients with difficult to treat eczema. The technique is not difficult. There's a little labor in filling the chambers, but that gets pretty rote pretty quickly. And you can really offer patients a comprehensive set of patch testing with a limited amount of time and effort. And then you learn the allergens as you go along. I'm just giving you an overview, but there's times you're going to come across an allergen, you're not going to remember what it is, and you just look it up and work with the patient on it. PPD, we always think about as being a hair dye. It became an allergen of the year, not because of hair dye change. It's been in hair dye for the entire 20th century, right? But it's when it started to get used in temporary black henna tattoos, right? And I know these are okay for anyone that could read these, but when you ask patients what do these mean, they'll often say harmony, peace, strength, that kind of thing. But I'm not. I mean, call me an irascible New Yorker. I'm not sure this dude is necessarily fluent in Mandarin when they're applying these, and sometimes they really don't say anything, or they're something like, employees must wash hands or something like that. So we see these temporary henna tattoos being placed, but they are loaded with paraphenylene diamine. The allergen isn't the henna. The allergen is the PPD added to make the henna endure and turn black. Normal henna tattoos are an auburn color. They're used in ceremonial Indian weddings, and they're on the palms, but henna doesn't give you a black color. It doesn't give you a brown color unless you adulterate it with a phenolic. So patients will often present with overt acute allergic contact dermatitis. Their ears are twisted up, their head's the size of a pumpkin, and they've had hair dye. But sometimes it's this chronic anterior scalp dermatitis that looks all the world like Sebderm, but doesn't respond. And yes, you dye in your hair. Yes, does it tingle when you put it on? Yes, okay, let's test you and see if there's any relevance there. And it often can be uncovered. So on the top left, we have paraphenylene diamine. We have a phenolic ring, and we have two amines, diamines in the para position. It's a very simple molecule, but it's pretty sensitizing. And when you put a 2-methoxymethyl in the ortho position, it sterically hinders the molecule and makes it much less difficult to sensitize. And it comes under this brand of Wellicolistin as a permanent hair dye in patients who are PPD allergic. Probably 2/3 of PPD allergic patients can tolerate this one, although I have them do a allergy alert test, which I'll show you. And then the semi and demi perms look very different from paraphenylene diamine. And those are sort of pigments that stain the skin different than the hair dye does. And sometimes PPD allergic patients, they'll often actually be able to tolerate semi and demi perms, permanent colors that'll last 3, 4, 5, 6 hair washings. But patients can get a very substantial facial dermatitis, and you see she's blistering to the paraphenylene diamine and may have a little action on the bottom. H is the hairdresser series. And notice she's also reacting to a textile dye mix, because paraphenylene diamine can cross-react with certain textile dyes. The allergy alert test is a home test. You're suspicious about a hair dye, you have them mix up the product at the salon or at home as if they're going to dye their hair, and just put a little bit on the upper arm or behind the ear. So in paraphenylene diamine allergic patients, if you put it on the arm or you put it behind the ear, more than 90% of the time you're going to detect it. You put it on for 45 minutes to an hour and then rinse it off. Have the patients take a look at it the next day, the day after, and on the third day. I always give them 3 tries to see if there's any redness. I had a patient come in today, on Tuesday, who was doing the allergy alert test by applying the allergen every few hours for 48 hours, which is a great sensitizing, event if it's not meant to apply that often. And every patient with severe reactions to PPD were positive to the allergy alert test. So those really serious ones you're going to capture. And everyone with a negative PPD patch test were negative on the allergy alert test. It's a very good test to capture patients in a practical setting without the patch testing. Now, fragrances, again, you saw on the top, they just commanded the top of that list with the preservatives. Fragrances are probably #1 family of patch test positive allergens out there. And about 1/5 to 1/4 of your patients are going to be positive to a fragrance chemical. And fragrance sensitive patients, again, tend to be Caucasian women over 40, and it's on their face, legs, and anogenital dermatitis. This is something, again, you have persistent anal itching or genital dermatitis, scrotal itching. We don't think of contact, but it's a good one to go to. And fragrance mix 1 and 2, very good starts with balsam of Peru, but you're going to miss most of the contemporary fragrances like linalool and limonene and the oak mosses, the tree mosses, the cinemates, if you don't test. And the sensibility of fragrances changes over time. I remember my grandmother in the 1970s. She always smelled like roses, like rosewater and naphthalene. She always smelled like roses and mothballs. And all the old ladies that she was friends with all smelled the same way. Well, people don't smell like roses and mothballs anymore. They like more natural and earthy products. This was just a couple of weeks ago. I gave a talk at the New Jersey Allergy Society, and in the hotel were these 3 things. You had rum body wash, cilantro hair conditioner, and peppermint shampoo. By the time I was done with the shower, I smelled like a drunken pirate who had used a breath mint. It was just crazy. Why does anyone want to smell like they've been drinking first thing in the morning? And this stuff does smell like rum. And when you dig into the ingredients of this rum bar, you have linalool, geraniol, citronellol, limonene. These are the emerging allergens of the day, and we're in the top 10 allergens that I showed you earlier, and were just recently added to the standard series a few years ago. So that's the amazing part of this. These are emerging, and when they get added to the standard series, they're debuting in the top 10 and 20. So we always have to keep our eyes open. Propylene glycol.
Questions. Sorry. Sorry. While I was laughing over there, we have a few questions coming up. So Kelly Noska asks, and I think this probably goes to a lot of folks here who are saying, this sounds so interesting. So what other resources can we use apart from the ACDS Camp app? And I'm sure one of the things you're going to say is becoming a member of ACDS. But are there?
That's so gratuitous of me, but I would say that. But I would say, having Fisher's textbook is not a bad resource. Or honestly, these days, if you just went to PubMed and pulled up an allergen you were thinking about, you're going to find tons of it. And the Camp app and the ACDS website has information sheets that I give. As you know, Toby, when someone's positive to limonene or quaternium 15, they're going to get in the mail an information sheet about every single allergen. A great one, though, guys, is there are multiple suppliers out there, Dormer, Chemotechnique, Allergies. We often use Chemotechnique. You go on the Chemotechnique website where you're buying the allergen from, right? And if you search the allergen, they have information sheets that describe everything you need to know about that allergen, and you could copy for the patient. So you don't need to be the expert. It's already there. And then you'll learn with the patient on some of these quirky allergens that come up. But limonene and linalool, I challenge all of you, go home, and tomorrow when you take a shower, look at your shampoo and conditioner, and I bet half of you to 2/3 of you find those allergens in there. And they smell delightful. They're wonderful. And I love using them. Unless you're allergic to it, no problem using them.
We also have another question that asks, does the Dormer North American Standard 80 contain the appropriate concentration of Chathon, MCI, MI?
Yes. Yeah. The North American 70 and 80 resets every 2 years, and they're always keeping up with the right concentrations. Because even things like formaldehyde and chromium, the concentrations will start to shift, and you don't have to think about it. You don't have to be that on top of it to know that.
Absolutely true. And then there's another question that was asked, but this is probably more directed for me. Can we have APDerm give us access to the CAMP database? We actually do have that, and that's just a note for me to make sure that I share that with folks. Although we do recommend that if you want more information, you can become an ACDS member, but we'll chat more about that later.
Yeah, I mean, I see there's like 65 people on the call, and what often will happen is, you know, you have multiple sites. There often people will start to just gravitate towards it and get, the more you do it, the more you get interested in it. And, you know, just let me know, or we can, you know, not, you know, you apply for it and they'll ask us for a reference and we'll give it to you. So you'll see how your interest evolves.
So much. All right.
Yeah, no, go ahead, Toby.
No, there's no more questions for now.
Okay, there's just a few more allergens left. Propylene glycol, you hear about all the time, and this is a bona fide confusing one because it causes irritant dermatitis, allergic contact dermatitis, contact urticaria, and it burns and stings, right? So when we use crisaborole ointment, it's got a lot of propylene glycol in it. Is the crisaborole or is it the PG causing the burning when it goes on? Hard to tell, but it's in a lot of products. I test for it at 30% and 100% to get some sense as to where that person is reacting. But it's a good one to have on because when it's positive, you could be sure you yourself have been prescribing PG containing products to that person. And all you need to do sometimes is just flip that out, get their personal hygiene products in line, and you're set. Polyethylene glycol sounds like propylene glycol. It's like England and New England. They sound the same, but they're not. PEGs are very large polyethoxylated molecules. They're really big. They rarely cause contact dermatitis. Polysorbates are very similar. And PEGs are in things like laxative bowel preps, like the ones you might use before a colonoscopy, or just use for regular constipation. But they also happen to be in most of the COVID vaccines. And we thought some of the early immediate type hypersensitivity reactions may be to polyethylene glycol hypersensitivity. It's probably not that common as a real cause, but I just wanted you to be aware of that we're rarely stopping people. I don't say never, but rarely stopping people from getting the vaccine. Cleansers, and when I use this as a general term, these are skin cleansers, those that need water and those that don't need water, but they have a lot of PG in them, they have fragrances in them, and they have a lot of preservatives in them. They're common causes of contact dermatitis. But what I've been coming across more recently are these arm and elbow dermatitis patients. I really am seeing more of this. And it's because surfaces are being hyper-sterilized and there's residues that have surfactants and have preservatives and fragrances, and people are putting their arms down on them. I'm going to wrap up with a couple of others. Acrylics, gosh, a really complicated, really complex chemistry here. They're in adhesive, so people say like I'm allergic to Band-Aids, or they're rubberized products. They're in artificial nails, hair sprays. They're even in fragrances to help them stick or to be thickened. They're everywhere. And we come across them and they're sometimes hard to diagnose. So when the patients come in with adhesive allergy, it may be difficult to track that down. It's just an interesting patient who had rubber and some acrylic allergy, got prostate cancer after the diagnosis, had invasion into his bladder, and they intended to put a urostomy in. And I said, I don't know if you're going to be able to tolerate a urostomy because of all your contact allergens. And I said, we got to make this impressive for the urologist. I said, have him give you 3 urostomy bags and just put them on for like a day or two, and then pull them off and take pictures. So this is a day and 2 days later. And that imagery convinced the urologist and the patch testing results that he needed to create a neobladder and not put a urostomy in. And he did, and his life is just infinitely better than not using a urostomy. So I was able to press that. The reason I brought up acrylics, because the 2020 allergen of the year was isobornyl acrylate. And it's a photopolymerized acrylic that turns out is in many, not everyone, but most continuous glucose monitors, and then some of the continuous glucose delivery systems. So It's in Dexcom, it's in Freestyle Libre, and it's in Omnipod that delivers low levels of insulin. The Eversense one, though, that's shown here, probably doesn't have isobornyl acrylate, but we tend to see it in other medical devices. This was from a blood pressure cuff that caused a whole arm of allergic contact dermatitis. And this is an old post-inflammatory hypopigmentation from a Freestyle Libre where the person was allergic to isobornyl acrylate. So it was like a double whammy. Now, I swear I'm not making this up. I thought I was rolling my eyes in the 2021 allergen of acetophenone enzyme. I'm like, this is so rare. Why are we even bothering with this? And of course, I saw a 13-year-old with who plays lacrosse with terrible dermatitis on his arms and hands, and he brought in a bag of sweaty protectants that may actually be allergy to acetophenone enzyme. It's in the vinyl acetate polymer that's used as the hard part of the shin guards or the elbow guards. And this is an evolving allergen. I think this is going to come and go pretty quickly. And I know the last thing the thing you've been waiting for, the last slide or the last two slides, are what the 2022 allergen of the year are. And again, I don't think a great one, but it's aluminum. I don't think it's a terrific allergen because I don't think it's that common. Aluminum, it's obviously in a lot of alloys of activities of routine daily living. We come in contact with aluminum in our vaccines as an adjuvant. We can patch test to aluminum chloride and petrolatum, and it's not available commercially, so I'm having it made myself. But dry Sol's aluminum chloride, it's just in a different vehicle, and you might get away with just using that. And the reason this became an allergen of the year is we used to use thin chambers, which were aluminum. Now I tend to use plastic chambers, Hayes chambers, and I don't tend to run into that. But I have written a few articles on aluminum allergy as it relates to vaccines, and it's mostly kids who get this deep granulomatous reaction to vaccinations or get a very enduring red plaque over the vaccination site. Not the thing that you and I might get for a few days over a vaccine and it kind of hurts a little bit and it goes away. These are more enduring. And if you look, vaccine excipients to very common vaccines have aluminum in them. And the CDC website has all the excipients for patients to avoid or try to find an alternative vaccine. So aluminum's out there. I would not get too worked up over aluminum. And that's the most current allergen of the year. And I could sort of stop and take questions, but I hope you recognize there's going to be clinical scenarios, some of which probably resonate with you, where you might say, I'd just like to know if it is an allergen. Don't approach the patient and say, I'm going to patch test you to find out what you're allergic to, or I'm going to patch test you to find out what the cause of this problem is. I think that's the wrong approach, and it sets up for failure. A third of your patients are going to be negative on the patch test. And a good number, maybe another quarter, will have a positive patch test that turns out not to be relevant, right? So what I always tell them is, I say, if there's an allergy here, and there's some suspicion that we have that there is, I'd like to find out what specifically that allergen is. If it's negative, it's great because it gives us freedom to operate, and I can have you use moisturizers you like. I can write you topical meds without worrying about the ingredients. So negative test, very valuable. Positive test, very valuable. It's a no-lose situation if we go ahead and do the test. It's non-invasive, no needle sticking or scratching, and we could test most of the important chemicals in your daily living. So thank you for your attention.
I totally agree with you. And that is there's always something to learn when I hear your presentations. And it makes me think about a new patient I just saw today with 2 episodes of an eyelid dermatitis, had nails, and had the new fake eyelashes.
Yeah.
And makes me really want to make sure that we get that extended patch testing at Mystic Valley, so I can kind of test for everything rather than trying to rely on the true test, because there's some things I would definitely miss. We have one more questions here. How do you counsel patients on the acrylic allergy who have to wear the ostomy bags, I guess after you test them, or who have to wear the continuous glucose monitors?
Yeah, great question, because it comes up quite a bit. So if we can get a device like Eversense that they don't react to, that's sometimes preferred, although it's not always available, or not, their insurance won't cover it. And I think some of these devices are getting smarter, and they're not using isobornyl acrylate. And ironically, it's not in the adhesive, it's in the body of the unit itself. But in the event you're stuck with that, I'm just going to give you some therapeutic advice. And that is, I tend to use either betamethasone or clobetasol foam. It leaves almost no residue. It has a long chain fatty alcohol, like some cetyl alcohol in there, but it's mostly alcohol. And I have them put that on, let it dry, which will dry in a very short time, and then put the device on. And then I commonly will compound tacrolimus in ethanol. So tacrolimus is pretty soluble in alcohol. The problem is you can't use any creams or ointments because nothing will stick. So you have to deliver the therapy with no residue. So you can use alcohol-based solutions. Sometimes clobetasol solution will evaporate well enough, depending on the generic, and you could stick. But other times I just use the foams, and I do use tacrolimus a lot. And sometimes they're changing the devices every 2 weeks or every week, so you're not really overdoing it. One last tip is, if it's an indwelling, if it's a device that's moving around, have the patient pick the next location and treat it with a little clobetasol for a day or two before you might sort of you sort of numb the dendritic cells, so they're not ready to wake up when the device is on. And again, tacrolimus in alcohol, or a little clobetasol, or if you don't need something so strong, betamethasone in low residue vehicles.
That's great. We have a question from Dr. Ryan, who is saying, for eyelash extensions, are you seeing an allergy to the glue? And I feel like I've seen 2 or 3 patients with eyelid dermatitis who happen to have had some of that. And I don't know if more people are seeing that. I haven't had the pleasure of patch testing them yet, so I don't truly know, but I'm sure you may have done that, Dr.
Yeah.
Cohen.
Yeah, I would test them. They're often formaldehyde-based glues in there. So you might not pick up the specific glue, but you might pick up formaldehyde. And some of the problems with these glues are they're coming from overseas with shoddy packaging, and you really don't know exactly what's in there, but you can inferentially diagnose them with a positive patch test of formaldehyde. It's the same thing with the Brazilian hair straightening, right? If you look at the packages, most will say no or low formaldehyde. And when you do high performance liquid chromatography, every one of them has formaldehyde, right? Every one of them. So you can't always rely on the label. You have to rely on your gut. And when you see these positive patch tests, why would a 33-year-old be allergic to formaldehyde, right? It's probably coming from some of the devices or glues they're using on their eyelids, and they have eyelid dermatitis, right? You put 2 and 2 together on that one.
That's great. So this has been amazing. I don't know if anyone has any last minute questions, but we want to definitely be respectful of your time as well. But I've learned a ton, as I always do, from you. So thank you so much for sharing your time with APDerm. Any last minute questions?
I'm here for comments and questions. As you guys grow this, you're going to have questions.
Dr. Cohen, I really enjoyed your talk very much. I was wondering if you could go through the range of protocols that you use for placing, removing, and reading. Logistically, since some of us are only in certain offices on certain days, and it's always easiest for us to read our own patches. We sometimes need a little flexibility on especially the removal date. Maybe you could just give us some insight of what's legitimate.
Yeah, and you know what? It's a very important practical question because it doesn't always work perfectly, right? The Monday, Wednesday, Friday is great. And I tell you, from 1930 to when I took over the unit, it used to be they were on Tuesday, they were only on Tuesday, they were off only on Thursday, and they were read on day 7 on Tuesday. And when I got there, none of the data forced us to do that. And this way, patients didn't have to go over the weekend. So let's say you're in your, let's say you're in the office on a Tuesday, and you're only in that office on a Tuesday. What I would do is have you don't have to be there for the application. You put them on a Wednesday, you remove them on a Friday, and you could read them on a Tuesday, right? Or you could put them on a Friday. I often will put on a Friday and have them off on Monday morning. It's okay, the extra 12 hours, not a big deal. And then you can read them on Tuesday. So they need to be on 2 days, right? If they're on a 3rd day, you haven't hit any penalties there, right? But 2 days is enough. I think 1 night is probably pushing it. I've done it on extremely rare occasion. There's got to be an extenuating circumstance for it, but I think you'll miss some. And I've done some studies to look at short contact. The shorter the contact, the more variable the reading. But basically, if you remove them and give it at least a day to breathe, right? If you read on the day of removal, you stand a chance of missing 1/4 to 1/3, even more, in my opinion, of the positive tests. So again, you don't need to be there, but pick the date where you are. The removal should be at least the day before. But remember, 70, 60 years, we were doing 48-hour application and we were reading on day 7. So if you read on day 4, 5, 6, 7, you're okay. And very critical, on the removal and the mapping, you take pictures. My chart is filled. You see all those pictures I showed of backs? Those are all the medical assistants, LPNs, removing them and mapping and taking pictures. And we usually on average have 8 pictures per back. It's a far one where you get the whole back. It's a half back and a half back. And then every panel should be you don't need a single shot with every panel, but I get upper left quadrant, upper right quadrant. So if a day or 2 goes a little bit longer and they start sweating the tape or they start sweating the map off, you have the photos, you know where the allergens were. So, but you have the flexibility. You do. This is delayed hypersensitivity. You're not going to miss it if you're a day late or doing it a day after the removal. But there must be time, a day between the removal and the reading. And you can spend 3 days later. Day 7, day 8 at the end is okay.
Yeah, thank you. That's very helpful.
Great. Thank you so much. I was going to ask another just very quick question. If someone has the rash on their back, where else can we put the patches?
Yeah, that happens. Look, you can either try to clear it and put as much time between the last topical steroid or prednisone or cyclosporin and doing it on the back, or you could use the flanks. You can use the thighs. The problem is the patients can get a little squirmy and it's hard to keep them. The back was picked because in like 1883, Yaddison felt it was the easiest place to plaster the allergens onto people, right, without them moving much. So the back turned out to be just a sensible place for it. And we do standardize concentration of allergens to the back, but I use the flanks and thighs when I'm my back to the wall. And it's okay to do that. You just need to tape them up a little extra hard and photo a lot, because things might get difficult to remember. Where's panel 60 to 70 again? Where do we put that?
Thank you so much. Great practical advice. So we could definitely let you go, and I hope we can ask you more questions, because I'm sure folks are going to send me an email about different things that they want to reach out. So thank you for extending that offer earlier on.
Yes, Toby, you know you can always reach out. You're a superstar, and we're always available to you.
Thanks, Dr. Cohen.
All right. Thank you guys again. Hope to see you at the Academy.
See you next month.
Take care.
All right. So Heather, we can switch.
Yeah. Give me one moment. All right.
All right. So we're excited. Oh, sorry. Go ahead.
I'll sign off now. Is that all right?
Yeah.
Thank you.
So we have Dr. Hanfield here. And then we have some quick announcements, one from Dr. Goose and one from Sherrod. And then we have a brief presentation by Tom Holguin from Sun Pharma on Winlevi. So, Dr.
Can you guys hear me okay?
Yes, we can.
Can you guys hear me? Okay.
Yes.
My internet says it's unstable, so we'll see how this goes. So I'm going to just tell a little bit about a neat case that I hadn't seen in the 11 years of my academic medicine before coming to APDerm. But a few months ago, I had a patient come to me. You know, the presenting complaint was acne, and when I came into the room, he really didn't have any acne on his face, just had some stuff on his neck. I'm like, that really doesn't look like acne to me. And I asked about his chest, and yeah, I have some there. And then I saw his axilla, bilateral axilla, and I see these, you know, very tiny erythematous and hyperpigmented papules that are coalescing into these plaques. And so I obviously knew I wasn't dealing with acne, so we had to get a biopsy. And you know, my differential was Fox Fordyce, you know, steatocystoma, vellus hair cysts, maybe granular parakeratosis. But what came back was syringomas. So, you know, I was a little bit surprised by this. I had to do a little research, and you know, we think of syringomas; they're obviously very common, typically face, women. But we also see it in Down syndrome. We know that it's common there, and then there can be some familial cases. But apparently, you can have eruptive syringomas in kids, particularly after puberty. And that fits about with this kid. He's 15, and it started about a year or two ago when he started getting these spots. So it's rare, but you know, it's typically, as was the case in this patient, it's asymptomatic, and it does typically involve neck, chest, and axilla. Can be other places too. And so, you know, it's typically a cosmetic concern more than anything else, as was the case with this patient. So isotretinoin does not work with this, so it's more ablative therapy. And so my initial thought was probably CO2 laser, ablative CO2 laser would be what we would need. But I decided that the patient really wanted to try something with a mom, and the patient wanted to try something in the office. And so I had my hyfricator. And so we tried a few lesions of the hyfricator, and just heard back from them actually today. And they are relatively pleased with the results. They're, you know, it got rid of, you know, over the course of, I think it's been about 3 weeks, you know, they're actually happy with the results of the hyfricator. So I'm going to do more of that. I don't know if it's going to be a durable response. You know, I have my sense that it's not, but, you know, we'll see how it goes. And I can certainly give you guys update on how the hyfricator works long term. But, you know, one thing that resolve on its own later in life. Anyway, an interesting case.
So that is very interesting, Kent. Thank you for that case. I've only seen it on the eyelids, and treated with electrofulguration lesions with some decent cosmetic results. I was just curious if there was anything on your reading or your thoughts, whether using axillary Botox injections would have any effects on the appearance or or make them quiescent for a period of time.
I hadn't seen anything about that. I'm just trying to think how that would work in terms of how that would make the lesions themselves regress. Yeah, I'm not. Yeah, I haven't seen that, but it's an interesting thought. I can look into that a little bit more. But I was wondering what your thought process is behind that.
Well, being the syringomas being related to sweat glands and they're in other patients, I get the history that they go up and down, and whether they obviously I haven't read about it. It just came to my mind, and a test site might be worthwhile just to see if there's some flattening of lesions and improvement in appearance, because it's obviously a safe place to inject Botox.
Right. That's a good thought. Yeah, maybe I'll talk to them, the patient and the mom, see if they're interested in that.
Do any others on this conference have any experience in extensive syringomas, successful treatments or unsuccessful treatments?
So I remember when I was in training, we used to use an erbium laser for folks that had this, but that's very similar to CO2 in terms of what it eventually does. So sometimes I like to take a step back and say, I mean, even though it's not necessarily always associated with a syndrome apart from Down syndrome, it really feels like one has to ask the question why. Just because there's just so much in the axilla. So I'm wondering if there's anything else positive in his history, or any family history of any other growths.
Well, so no other family members have had anything like this. So there's nothing that supports the family history. And as far as I know, he's had normal development, no, congenital issues. So.
I did a quick Dr. Google search and found that Botox has been used as a monotherapy for syringomas with very good success. So
great. Well, maybe we'll give it a try.
Looking into that more.
Yeah.
Well, yeah, I want to thank Dr. Hanfield and of course Dr. Cohen today. This was a great meeting. It makes us all think about what we're already doing and what we maybe should be doing. I think that's a great thing about our practice in general, that we always try to do things in a thoughtful way and really work together to come up with the best solutions for our patients. As we know, the AAD is the ultimate meeting where we can share with our colleagues, learn from people like Dr. Cohen, and work together. We're very lucky this year. First time I ever recall, the AAD is in Boston at the end of March. We, as a practice, which we'd like to have the ability to network with area dermatologists, are going to have a a nice presence at the meeting. We would like to know if you're attending the meeting. We're trying to come up with events that would make your meeting even more enjoyable. And we're hoping, we'd like to know who is attending. If you could just send an email to Physician Advisory Council at APDerm.com, just to let us know that you're attending, and we can keep you on our list of people we should reach out to as we come up with different ideas. So I very much appreciate it. On the topic of learning and teaching, I wanted to bring to everyone's attention a recent opportunity that I became aware of. I had a nice conversation with Rhoda Alani, the chairperson of the BU Dermatology. I'm a graduate of the BU Tufts Combined program, and when I finished up residency, I had the pleasure of keeping a resident clinic going for 7 years. It was very stimulating. Residents can ask great questions. We know that Dr. Rosenbaum, one of our colleagues, is on the faculty at BU. Dr. Grande is on the faculty at BU. It's a great training program, a growing training program. And Dr. Alani was hoping that we could muster up some volunteer faculty. In turn, I'm hoping that I could work with all of you to come up with, at the very least, a clinic that we could call the APDerm clinic, and we could cross cover for each other. I'd like to know what your thoughts are on being a volunteer faculty at BU. You would receive a volunteer faculty academic title for doing this. There would be no payment for your time, but by grouping together, there's the opportunity to just be able to come once a month for a half a day, and that would give you that sort of stimulation, keep your lifelong learning going, and help contribute to the future dermatologists at Boston University. Please let me know if you're interested. We'll maybe do a follow-up meeting if you are, and see if we can come up, ideally with use of our academic administrative time, a way of putting together one or more clinics that can contribute to Boston University. Just email me at sgoose@apderm.com with your interest. Thank you.
Thank you so much, Dr. Goose. I think many of us are already involved in teaching. I have been in the past and would definitely love to continue that opportunity, because it sounds like it would absolutely be stimulating. And also, I know I'll be going to the AAD, so I look forward to seeing many of you there as well. I think Sharad was just going to give a few words about the next thing.
Yes, thank you, Dr. O. I was very fortunate. I got to spend several minutes with probably each of you to talk about sort of your 2022 goals and also some of your pain points. And some of our takeaways were that there's just a lot in terms of the infrastructure that we need to invest in, whether it be training, management, leadership. And so those are all areas that our senior leadership team and the directors and managers have all come together to develop a plan that'll put us on a better course for 2022. So we're looking forward to next month's medical education meeting. Mark and team will be presenting to all of you sort of what those 2022 initiatives are and those goals. And so we're looking forward to sharing how we're going to improve the infrastructure and better support you in your practice. Thank you.
Great, thank you guys. So I think now we are going to have a representative from Winlevi just speak about this new medication. I know so many people have asked about it as it adds one more tool to the acne toolbox that we have. I actually just had a patient, a 12-year-old who was put on spironolactone by someone else. And we were trying to discuss, even though they had hormonal acne, if there was another option for them to go on. So this definitely came up in that conversation. All right, so I will pass the presentation to Thomas, who's going to speak. I don't believe we have a clinician now, but I think Tom and his partner are very knowledgeable in terms of what all the clinical facts about this new drug.
Yes, ma'am. Good evening. My name is Tom Holguin. I'm with Sun Pharma, and I'm joined here with Rhonda Schreiber, who's the Director of Professional Relations on the East Side. For the sake of time, we'll condense this 2-hour presentation into the 10 minutes that you've asked. And I think a good way to start out is to, first of all, as we discuss what Sun Pharma is about, we do have 2 products in the medical dermatology environment. One is Absorica LD, which is our new micronized technology built into isotretinoin. And what we're here to discuss today is Winlevi. And I think a good way to start off here is to review the package insert actual indication, which says that Winlevi cream is an androgen receptor inhibitor indicated for the topical treatment of acne vulgaris in patients 12 years of age and older. And as we go through the presentation, I think you're going to find that there's going to be some wonderful utility for what Winlevi can do for you and your practice in treating acne vulgaris. As it goes, and I just want to level set everybody. I know that everybody's well entrenched in understanding how androgens play out and the pathophysiology of acne, but I think it's fair just so we can level set for those that know a little bit more about it to allow everyone to get caught up on how Winlevi can play out in this androgen area. Well, first of all, we all know that the androgens kick off for both males and females. I want to reiterate males because I think, as we'll discuss later, one of the limitations for treating with some of the things like spironolactone or contraceptives has been, how do we help out the male patients? And in this case, when we start talking about androgens, it's just good to know that when we're talking about the types of acne, it really is not limited to hormonal acne. There's all kinds of acnes that play out. It does affect males it does affect males and females, and it starts from, like I said before, through puberty all the way through as we get older. In terms of the current treatments that we have, unfortunately, some of the oral treatments that you've had to play with have not allowed you to address that sebum production. Hyperkeratinization, inflammation, C. acne is taken care of well by other medicines, but the one part that's always been lacking is how do we impact, as Dr. O mentioned, how do we impact topically sebum production and inflammation? That's where Winlevi is going to play out for it. It's for it to cover the mechanism of action, and as you all know that things like DHT and testosterone utilize the androgen receptor to go ahead and bind, and that's what increases sebum production as well as inflammation. And it is seen with Winlevi, even though the exact mechanism is not known, it is thought that Winlevi competitively binds to that androgen receptor, thus blocking DHT and testosterone from binding to that androgen receptor, and therefore receive sebum production as well as inflammation decrease. And what I should point out here is that unlike others, it's really having no other, and maybe Ron, if you can correct me on this, no other effect on DHT and DHT and testosterone. It really is just blocking the ability for DHT and testosterone to utilize the androgen receptor.
Yeah, Tom, that's correct. It's so heavily metabolized in the skin, so rapidly metabolized that you don't see any systemic effect on any of the androgen or testosterone impacts on the rest of the organs of the body.
Thank you. So I'll just take a pause. Any questions regarding kind of like the androgen story as we get up to discuss a little bit about efficacy? So I'm going to be referencing two studies that come out of.
Sorry,
yes.
I do have one question. There was a question that was asked prior to the meeting about just clarifying like the Hpa Axis suppression and why. So why is that there, and has that been seen? So even though you said it's not a major issue, I think some folks were just a little bit nervous about this, especially as kids go through puberty.
Exactly. Rhonda, I'll let you handle that.
Yeah, sure. It's a good question, and everybody's asking it, just so you guys know. So our active metabolite is cortexolone. So when we're absorbed, penetrating the skin and then permeating into the layers of the skin, it's rapidly metabolized into cortexolone, which is a weak glucocorticoid. So there would be some level of glucocorticoid reaching the systemic absorption, but it's very, very minimal. So we actually went looking for it because of that. We went looking and did a PK study, and at 4 to 6 times the maximum dose, even then, they saw very, very, very little effect on CST testing. So only ever a laboratory impact on HPA suppression, never actually any clinical impact, and nothing in either the phase 3 or the long-term safety study, which went up to 12 months afterwards. So it is everybody's question, but that warning is there because the active metabolite is a steroid. And if you have any potential, you guys know, any potential for impacting the hypothalamus, you have to have the class warning. So that's why it's there. It's not that it was a side effect. It was in the PK studies.
Thank you.
Super. So transitioning over to efficacy, I'll point out that these studies are in the package insert done by the short-term 12-week trial was done. Lead author was Dr. Hpa, including Dr. Steingold, and the long-term safety trial included Dr. Eichenfeld as well as Hpa and Steingold. Both were produced in 2020. The first one with looking at our 12-week efficacy was a report out of JAMA Dermatology, and the second one was JAD, still 2020. In terms of the short-term trial, the 12-week trial, it's pretty stringent criteria, taking patients who are moderate or severe and active based on the IGA scale. And once again, I should point out that there's co-primary endpoints. One was IGA scale reduction, as well as taking a look at inflammatory and non-inflammatory lesions. All were part of the efficacy part of the 12-week trial. And in the stringent success as monotherapy, Winlevi was able to help get treatment success in 1 out of 5 patients. And once again, that's at the end of 12-week at that very stringent criteria. In terms of lesion counts, they took a look at both inflammatory, and you can see here in the inflammatory lesions, absolute change to the left and mean % change to the right, as well as non-inflammatory lesions. In all cases, at the end of 12 weeks, Winlevi was statistically significant over the vehicle. And so in all 3 measures of the co-primary endpoints, Winlevi did achieve success. And I should point out, once again, I keep forgetting, but in this trial, 38% of the 1,421 patients were male. And so once again, as we start contemplating the utility of Winlevi, it's not a female-only medicine. It is female and male, and as was studied in these trials. Looking at long-term efficacy, and once again, I will point out this is a safety trial, but they did take a look at patients that had facial and truncal acne. And as you can see, Winlevi is demonstrating a growing positive effect in terms of helping people get their IGA score to goals. And so it does continue to progress. And it's similar to what we saw in the 12-week trial, where the longer Winlevi stayed on, the more improvements the patients saw. From an efficacy standpoint, also looking at total lesion count, the patients on entry, if we're talking about non-inflammatory lesions, had somewhere between 30 and 100. And if they had inflammatory lesions, about 30 to 75. I believe the mean was around 100 lesions for these patients. So they're pretty tough patients that you'd probably see in practice. Net drop was 40 lesions. So, we'll take a look at some pictures here of what this could possibly mean for your patients who are coming in with a lot of lesions on their face, going from 1 to day or to week 12. There's some benefits in there for the patients as we move forward. I'll stop here from an efficacy discussion. Any questions? Or Rhonda, anything that I missed?
No, I think you did a great job, Tom. The only thing I would add with the long-term safety study, yes, the efficacy did increase over time and they did study trunk data. But I think one of the key points with that study was that there was no accumulation of adverse events, no worsening of adverse events over time, and there was no systemic or steroidal side effects seen in that 12-month period.
Great. I'll continue on. So as we've already discussed, and I wish that, so if I make it around, if one of my representatives have to make it around, please ask him to demonstrate the vehicle to you. I think you should probably see, I guess it goes on elegant, and as Rhonda shared with me, the ability to penetrate, permeate, as well as the absorption. Because it is being rapidly absorbed into the skin, we're probably seeing a low incidence of systemic side effects. And in fact, 12-week local skin reactions, erythema, redness, pruritus, and scaling were all comparable to the vehicle. As once again, in the short-term trial, 9 out of 10 people on Winlevi experienced no treatment emergent adverse events. Of those that did, 3/4 were mild, and there were 0 that were any that experienced a severe treatment emergent adverse event. As Rhonda alluded, one of the things that we saw in our long-term safety trial, a report out of Dr. Eichenfeld, is the comparability between Winlevi and the vehicle, 18.3 versus 17.9%. And as she already pointed out, no evidence of libido changes or feminization in male patients. Any questions regarding the safety? Winlevi is dosed BID. It does come in a 60-gram tube. And so prescribing for Winlevi clascoterone, 1%, 60 grams, and BID, and for as many refills as you and your patient need. In terms of support, which here in the Massachusetts area, we do get the question, actually probably Massachusetts, Rhode Island, is what can the patients expect? And right now we've had just in the 3 months that Winlevi has been out, over 60,000 prescriptions have been written for it. And in part, we've tried to minimize the challenges a patient may have getting the medicine by offering this copay card. $25 if it's covered is most they'll ever pay for it right now. And then if they're not covered, it's $50. And I think it's up to you and your patients as to where they can go to get this thing filled. But for the most part, that is where Winlevi has been playing out, and it's been working nicely for the patients out there. So at this time, I'll go ahead and take a step back. I will point out that for you and your patients at winlevi.com, there is an opportunity for them to pull down a copay card in case we cannot come by and deliver it for you. They can get it. I will throw out, I'll take a step back right now and just see if there's any questions regarding clascoterone that you may have.
One point just to throw in for our folks is that if you would like to prescribe it, we really encourage you to send it to an Apotheco pharmacy. This just decreases the amount of back and forth on our end. And I believe Apotheco should have some access to the copay cards already. So it's not something that, that we should have to worry about. And you guys can feel free to correct me if I'm wrong.
You're correct.
Thank you.
So it looks like we have one little chat here. Oh, something different, sorry.
But this is great. If any questions come up, we'll be sure to circle back to both you, Tom and Rhonda. I know we are running late, like we almost always do. So thanks to the folks who have stayed on. And is there a way that we can reach? Oh, perfect.
I will say this. So we didn't have enough time to discuss, but I am the local sales manager covering all of New England, and if there is a request, if you need anything from samples to information, copay cards, I can work with my local representatives to ensure that they get it to the offices. There may be also questions about Winlevi that fall outside of the package insert, in which case I can help facilitate that by completing the medical request form. And Rhonda, if you want to just share briefly what your role is and how you can help out APDerm as well.
Yeah, so myself and my partner in the West, our role is really, well, professional relations pretty much sums it up, but it's an educational initiative role. So we're working on partnerships with the medical community, case studies, feedback to our marketing team about what would be more helpful for education, that sort of thing. I would also like to I know some of you said you're going to AAD. We will be at AAD, and we actually have 2 speaker programs occurring at AAD on Winlevy. So if you want to hear more from clinicians, Dr. Kurtzik will be presenting on Friday night, and Dr. Baldwin will be presenting on Saturday night. So Heather has my contact info. She has my email. If anyone is interested in attending either of those, we'd love to have you come. And that's an opportunity to ask, someone besides Tom or I questions about this. So yeah. Thank you so much for having us, folks.
Great. Thank you. We appreciate your time.
Thank you, guys. All right. Thanks to everyone. I will be sending out a summary shortly of the meeting, but this is another good one. Thanks, Heather. Thanks, Jamie and Mark.
Thank you, everyone. I'll be sending out the post-meeting survey momentarily.